Welcome to another lecture of Psychology 101. This is your instructor, Dr. Shadi Bashai. And in today's lecture, we will continue talking about psychological and biological treatments. And this particular unit corresponds to chapter 16 of your textbook. So here we go. So throughout our discussion on both psychological disorders as well as psychological treatments, I have been mentioning this type of therapy quite frequently. And this type of therapy is cognitive therapy or cognitive behavioral therapy, otherwise known as CBT in the literature and in the market. And CBT is a big umbrella term that includes within it a number of different psychological treatments. And the idea here is that all of these psychological treatments that belong to the bigger umbrella of cognitive behavioral therapy either focus on behaviors, so they help patients deal with their distress by changing certain actions or certain behaviors that they're engaging in throughout their lives, or even more directly now, dealing with some of the interpretations that they have about their events, about their circumstances, that tend to be negatively skewed amongst people with a vulnerability to psychopathology. Okay, so any psychological treatment that either deals with cognition or thought or interpretations, or if you will, behaviors, changing behaviors, getting more engaged, doing more mastery and pleasure related activities, scheduling these things into your schedule. All of these things can be put under the bigger umbrella of CBT. And within CBT, you have something which is the purest form of cognitive behavioral therapy, one of the very first forms created by Aaron Beck, which is called cognitive therapy. And then you have also one of the earliest forms of CBT, REBT, or rational emotive behavior therapy, created by Albert Ellis. And then you have more of the problem-focused and more of the behaviorally focused interventions, such as problem-solving therapy, and you have what we call the third wave interventions, that they don't necessarily focus on helping patients identify and challenge or dismantle the content of the negative cognitions or the negative interpretations themselves. However, these third wave treatments that also belong to the bigger umbrella of cognitive behavioral therapy, such as acceptance and commitment therapy, otherwise known as ACT, or as well as dialectical and behavioral therapy, DBT, and cognitive behavioral analytic systems psychotherapy, which is kind of a blend of psychoanalysis and cognitive behavioral therapy. But acceptance and commitment therapy and dialectical and behavioral therapy are examples of kind of what we call the third wave cognitive behavioral therapy, in the sense that they don't care about the content of the cognition itself, but instead they help or teach the patient to recognize when they're having negative interpretations or negative cognitions, and kind of learning to accept and learning to lean into these cognitions and know that thoughts will often think themselves. So learning not to be so engaged with these negative thoughts. And oftentimes, especially with something like depression or anxiety, part of what keeps the distress going, part of what maintains the distress and the symptoms of anxiety and depression going, is this association, if you will. So as soon as someone with a history of depression, for example, and this is according to a lot of research, as soon as they have just normative dips in their mood, what happens is negative cognitions are activated, and then they get engaged with these negative cognitions, right? So they're kind of swept away by these cognitions, and for that reason, these third wave interventions learn people to step back and just kind of watch or observe these thoughts as they come and go, and learn that they're not really part of self, these negative cognitions, but they're kind of transitory events in consciousness, if you will, that if you just observe them, they'll go away over time. Okay, so that's the bigger umbrella of cognitive behavioral therapy, which includes within it a number of different treatments. Cognitive behavioral therapy generally as an umbrella, but also cognitive therapy, which kind of started the whole thing, in this brand of cognitive behavioral therapy was created by someone by the name of Aaron T. Beck, who was a psychiatrist working in the 50s and 60s with patients who suffer from depression. Now, Aaron Beck was trained in a psychoanalytic approach, and his very first exposure to things such as depression was helping people with depression overcome their depression with psychoanalysis. So he was himself trained as a psychoanalytic psychotherapist. However, one of the big problems that Aaron Beck encountered is that many of the theories and many of the hypotheses that psychoanalytic theory had over something like depression. So, for example, they have a big theory which suggests that depression is really angst and anger turned inward. Okay, and the more he looked into it, the less evidence he found for some of these hypotheses or beliefs. So what he did was he instead found that people with depression, and again, this was one of the first conditions for which he applied his cognitive behavioral theory. He found that people with depression oftentimes have a very negative interpretation of themselves, the world, and the future, something that he later called the cognitive triad of depression. Okay, so he found that the content of their cognitions was really quite negatively skewed, and it was negatively skewed in three directions, if you will. It was negatively skewed about the self, the world, and the future, and actually helping patients recognize these negative cognitions and work through these negative cognitions, actually challenge these negative cognitions, made a lot of his patients feel a lot better. Okay, so that was the beginning of cognitive therapy. At the same time as well, Albert Ellis was designing and perfecting his rational emotive behavioral therapy, which rested upon the same theoretical foundations, which is that it's not so much that people's actual environments that are making them distressed, it's their interpretations of these environments. Okay, and that is how you explain some of the individual differences that you get. For example, two people could be fired. One of them can see this as a great opportunity to look for another position, maybe move up. Another person can see this as a complete detriment to their lives and as a catastrophic event. And depending on these two interpretations, one will more likely have symptoms of depression or anxiety than the other one. And of course, that's the second person thinking that this is a catastrophic event will be more likely to have symptoms of depression and anxiety develop. Anyways, so it was first described in the 1960s and 70s based on this clinical work that Aaron Beck and Albert Ellis did. And then since then, it has been subjected to thousands of research trials, thousands of different outcome studies and mechanistic studies. And all of this research has culminated into us understanding how powerful these set of techniques are that live within the umbrella of cognitive behavioral therapy. And since then, this treatment and its derivatives, if you will, has been recognized as an effective treatment for depression in the American Psychological Association Division 12. Okay, so this division does a lot of work. This Division 12 does a lot of work to figure out which treatments actually have evidence to support them, and they came out and they said CBT was one of the best treatments for depression in terms of evidence in support of it. The CPA, the Canadian Psychological Association, also had a similar revelation about CBT, and not only that, CBT is recognized or identified as an effective treatment for outpatients who have depression in the U.S. Department of Health and Human Services, as well as in the United Kingdom, a big organization by the name of by NICE, which is the National Institute of Clinical Excellence. They come out with guidelines every few years, and their guidelines really put CBT as the first line treatment for something like depression and something like anxiety. So CBT since the 60s and 70s has really been a success story. Here are some of the major claims, and I've alluded to these claims a second ago or so. CBT claims that how people think, how they interpret their environments, their cognitions, their thoughts, and their behaviors, the things that they do, their actions, as well as how they feel, right? So their emotions. These three things are always strongly related, okay? And if you change one side of this equation, if you change the cognition, if you change the behavior, or if you change the feelings, change will also follow in the other two aspects of human experience. So if you change the behaviors, change will also follow in cognitions and in feelings. If you change the cognitions, change is also going to follow in actions or behaviors as well as feelings, okay? So cognitive behavioral therapy makes this claim that emotions and behaviors and thoughts are all interlinked. And so if you change one side of this triangle, the two other sides will follow as well. So cognitive behavioral therapy has a particular focus and a particular target for the interventions that cognitive behavioral therapists use. And typically speaking, the focus of change is often cognitions or thoughts and behaviors or actions. Okay? And the reason for that is, the theory goes, if people can actually control their emotions, and remember, if you change your emotions, a change, according to CBT at least, if you change your emotions, a change in thoughts and a change in behaviors will also follow. However, it's much more difficult to focus and work on emotions because oftentimes they're so intense and therefore they're very difficult to work with. And for that reason, the target for intervention in CBT is often the thoughts and the actions or the behaviors. So there have been very specific hypotheses that the cognitive behavioral theory has forwarded regarding psychopathology. And these hypotheses, for the most part, have garnered a lot of scientific support. And the hypotheses go that people with psychopathology, so people that are vulnerable to developing conditions like anxiety, depression, etc., have more negative automatic thoughts about the self, world, and future, otherwise known as the cognitive triad. Okay, so they'll have these more, and automatic thoughts are these thoughts that lay just beneath the threshold of awareness, but they're kind of this running commentary on in certain situations, etc. It's basically our stream of consciousness, and according to a cognitive behavioral perspective, people who are vulnerable to psychopathology will have a more negative stream of consciousness than are people who are not vulnerable to this to psychopathology. Not only that, people who are more prone to psychopathology, more prone to depression, anxiety, etc., they make more unreasonable demands on themselves and other people. So they put demands on themselves such as, I should be able to get an A in the class. I should be able to get a job that pays me well. I shouldn't be feeling this way. I shouldn't be having depression. And so that these are the demands that they put on themselves, and they could also put similar demands on others. Others should treat me with respect. Others should be able to know when I am feeling bad, and therefore they should comfort me. Okay, so using these should or very rigid statements to think about the world, and of course there is no such thing as a should. And if something should be the case, then it would be the case naturally. Otherwise, then it shouldn't be at all. Okay, so there is no rule book, if you will, that says you should get an A, or you shouldn't feel depressed, or you shouldn't be sad, or people should treat you fairly or treat you well, etc. These are all things that we kind of expect of the world, but they're not necessarily demands that we can actually set with any degree of confidence, because there's a great deal of uncertainty in the world. Not only that, people who are more prone to psychopathology often, according to cognitive behavioral theory, often see the world in black and white terms. And this is what we call dichotomous or all or none thinking. Okay, I'm either good or bad. I'm either a success story or a failure. Not only that, people with psychopathology or who are more prone to psychopathology, according to the theory of cognitive behavioral therapy, they ignore positive events in their life or positive instances, and oftentimes they focus on very negative aspects of their life. Okay, so if they give a presentation and they give a presentation in class, for example, and they get a 90% on that presentation, but there was one comment that the professor made about, maybe next time try to slow down your presentation style, or maybe don't try to read as much, but you did a really fantastic job. They'll, instead of focusing on the positive aspects of that feedback, they'll almost entirely focus on the negative aspects of that feedback and really give themselves a hard time because of this one little negative comment that was made. We talked about cognitive distortions a little bit in our discussion on cognitive theories of depression. And cognitive distortions or errors in thinking is, according to cognitive behavioral therapy and theory, are these very systematic filters by which we sift through the world. Okay, so they're basically a certain style or shape of glasses that you put on, and therefore it shapes the world in accordance to that shape of the glasses. Okay, so if you have an absolute or black and white or a dichotomous thinking style as a cognitive distortion, or you do this very often, that's one of the things that you do, you're, as I was saying earlier, more likely to see things as very black and white. Okay, I'm either successful or I'm a failure. I'm either a good person or a bad person. I'm either a good student or a bad student. I'm either a considerate human being or I'm a complete piece of shit, if you will. Okay, so this is the black and white type of thinking that is this particular cognitive distortion. Okay, and of course the problem with often coming up with these dichotomous, either good or bad, considerate or completely inconsiderate, is the world is of course full of shades of gray. So there can never really be something that is entirely one side or another, especially when we're describing our own behavior and the behavior of others. You can't. It's likely not the case that you're a complete failure. It doesn't make sense given the fact that you are where you are today. In fact, it's very likely that you've had many, many successes. Therefore, is it really appropriate to say that you're a failure if you fail on one exam or if you don't do very well on a presentation? So that is the problem with this dichotomous type of thinking, is that there's lots of shades of gray in the world that this type of dichotomous black and white thinking doesn't really gauge very well. There is magnification and minimization, and I kind of alluded to this earlier as a cognitive style. And magnification and minimization is when you magnify the negative aspects of a situation and you minimize all the positive aspects. And I give an example of what that might look like in the previous slides. Like, for example, if you get pretty good feedback on a presentation, you may focus in on the negative aspects of that feedback. You magnify the importance of those negative aspects of that feedback, and you minimize perhaps how well you've done. You minimize the positive aspects of that feedback. There's personalization or negative attributions as a negative cognitive distortion. Personalization is when you take blame for things that you cannot possibly be responsible for. Okay, so if you're doing a group assignment and the group doesn't do very well, you take all the blame on yourself. This was all my fault. Or if someone gets upset in your family or a friend gets upset, that very much has, their reactions have very little to do with you, yet you think this somehow has to do with you. You personalize it. You make it your own. You say, you know what? I'm to blame for this. My friend is really upset because I made them upset. Okay, which is often not necessarily the case, and that's why it's a cognitive distortion. There's fortune telling or catastrophizing, which is this type of cognitive distortion that happens often in amongst people who are prone to anxiety. Okay, and there's another name for it, which is called crystal balling, and this is when you make predictions about something that you cannot possibly know how well it'll go, right? Or how poorly it'll go. So you make predictions about things that are uncertain, future events mostly. So you say, you know what, I'm gonna do so shitty in the presentation. I'm gonna do so badly on my exam. This party's gonna be horrible. I'm never gonna amount to anything. My future is really bleak. Okay, so we call this fortune telling, catastrophizing, or crystal balling, because again, it's a distortion because you're making assumptions about something that's really quite uncertain, which is the future. And oftentimes the prediction has a negative bent to it, it's negatively skewed. And therefore it doesn't account for all the positive instances when you went to a party and things were fine, or you did a presentation and things worked out just perfectly okay. But at the end of the day, we cannot predict the future. And that is why this is a cognitive distortion. There is labeling. And labeling is when you put a simplistic label on something that is very complex. Oftentimes it's yourself or someone else. Okay, so when you call yourself a no good so and so, if you call yourself a failure, if you call yourself stupid or lazy or whatever it is, we call these labels. And the problem with labels, especially as applied so simplistically over something that is so complex, which is a human being, essentially, is that they miss this complexity. Okay, so these labels very much so miss the complexity of humanity. And even though you might have done something lazily, or you did a behavior that had a pretty poor outcome, that doesn't necessarily mean you're a failure. It doesn't necessarily mean that you're lazy. It doesn't necessarily mean you're stupid. It just means you probably did a stupid thing, or you failed at one thing. And just to make this even more concrete for you, whatever room you're listening to this in, whatever environment you're listening to this particular lecture in, I want you to come up with a word to describe the room in which you reside right now. Come up with one descriptor. And think about this descriptor in your mind, and think about how simplistic that one label or descriptor that you had in your mind is to describe something as complex as a room. Okay, so some of you may say the room is small, the room is dim, the room is nicely lit, the room is cold, the room is hot. This one description misses a whole lot of aspects of the room, I'm sure, because rooms are typically need to be described in more than just one term. Now, imagine how difficult it is to put one simplistic label on something as complex as a human being, let alone a room. Okay, so this is why this is a cognitive distortion. Labels, by definition, are too simplistic, and therefore they don't account for all the picture. And then finally, there are should statements, which are these rigid demands that people put on themselves and others. And I've talked about that in the previous slide. I should be able to get an A in a class. Why should you get an A? Why is that a rule? In what rule book is this particular stipulation forwarded? Okay, and if there is a rule book out there, and you're saying you should be able to get an A, then you will get an A. So for that reason, should statements are cognitive distortions, and what they end up doing is they put too much of rigid demands on yourself if you're making these should statements about yourself, or on other people. And of course, the world is not that neat. Nothing really is a should. Nothing really is this hard and fast rule. So here's a depiction of all of these different cognitive distortions or unhelpful thinking styles that make people more prone to have these negative automatic thoughts, to have the negative assumptions, and finally, they're all probably stemming from schemas that emerged early in life that are typically quite negatively skewed. Okay, and it perpetuates these cognitive distortions, perpetuate the skewness, the negative skewness of the information processing system. Okay. So yeah, we talked about many of these, all or nothing thinking or dichotomous thinking, overgeneralizing, etc. But you now have a list of these cognitive distortions. And I guess one of the more important aspects of today's lecture is I really want you guys I want you folks to take on some of what I'm telling you about today, and I want you to apply it and use it in your own lives. This is probably one of the most important lectures that I have to give for this particular class, because in it I do describe I describe actual skills that we as clinical psychologists help our patients to learn in the context of psychotherapy. These skills have been found to be quite effective if done appropriately and done consistently in helping people deal with symptoms of anxiety and depression. And it's not necessarily the case that you need to have an official diagnosis of anxiety or depression to be able to find benefit or usefulness from these particular skills that I'm going to teach you about. But people, even with sub-threshold levels of anxiety and depression, even myself, when I'm having a particularly difficult day, I will revert back to using some of these skills that I'm teaching you about today. So it's really quite an important lecture in the sense that I'm really hoping you take some of the things that I'm telling you about today to heart and use it throughout continuously in your lives, especially when you're having a difficult time. And we all have periods of darkness or periods of particularly difficult time. So in the course of cognitive behavioral therapy, what we do is we first help patients identify what automatic thoughts they're telling themselves in particular situations. And oftentimes we accomplish this by sending people home with these thought records. Okay, and the thought records look very much like what you're seeing here today. There is a column that asks you to put down the date. There's a column for what is the situation. There's a column for what automatic thought were you telling yourself during that time, and then what emotion you were feeling during that particular situation. And I mean, for the most part, we only do the first four columns here in the beginning of cognitive behavioral therapy, and then later on, we teach patients to come up with alternative automatic thoughts that can apply to this situation that is likely more realistic. Again, cognitive behavioral therapy is about the power of realistic, helpful thinking, not so much about the power of positive thinking. We're not trying to wish away all the bad feelings. We're teaching patients, and patients are learning to accurate, or at least more accurately or more realistically assess who they are and assess the situation in which they find themselves in. Okay, so they come up with an alternative response that is almost like a response to this initial negative automatic thought, and then you record how that has changed the initial emotion that you felt based on the negative automatic thought, right? So I'll give you an example. Last week, let's say last week a friend of mine canceled lunch on me, okay? And that happened on a Tuesday. So I write down the date, Tuesday, May, whatever, and I write down the situation. I say, the friend canceled lunch on me. And usually I tell patients to record down what the emotion during that time was. And because that's a little bit easier to think about than the automatic thought, because learning to identify this stream of consciousness, if you will, these automatic thoughts that lay just beneath the threshold of awareness, takes a bit of skill to do. Okay, so first we talk about the situation. A friend canceled lunch on me. It was Tuesday, whatever. And the emotion felt based on this situation is there's a lot of sadness. And I rated the sadness, let's say, an 8 out of a possible 10. Okay, so relatively intense. And then I asked the patient to think back at the situation. Okay, and the closer you are to this particular situation as you're doing this exercise, the better, because it'll give you a better gauge of the automatic thoughts. And I tell the patients to really place themselves in that particular situation again, really put themselves there in their minds. What automatic thoughts come to mind? What thoughts are immediately available to them? And many people, based on the situation, who are prone to depression and anxiety will tell you something like, it means that they don't like me. It means because my friend canceled lunch plans on me, they don't love me. And then I'll tell them, well, so what does that mean? That this particular friend doesn't like me? Well, it may mean that no one will ever like me. Okay, which is really the more you get down to the roots of some of these automatic thoughts, and I'm not suggesting that I just did that just now, right? When I asked, what does that mean that this friend doesn't like you, and then the person says, well, it means that maybe I'm unlovable. The more you go down to the roots of these automatic thoughts, the more you'll resemble these schemas that we talked about in the past. But anyways, so they say, my friend doesn't like me. My friend doesn't like spending time with me. Maybe that's the automatic thought that they're having. And you associate that automatic thought with an emotion, which is sadness. Makes sense. If you think your friend doesn't like you, if you think your friend doesn't like spending time with you, chances are you'll feel a little upset about it. But is the automatic thought actually true? Is it actually true that when a friend cancels lunch on you, or is it always true when a friend cancels lunch on you that they don't like you or they don't want to spend time with you? And that is really where cognitive behavioral therapy lives, is teaching patients to evaluate these negative automatic thoughts and come up with an alternative response or explanation. Well, what else could be true? What else could be true about that particular situation? Well, it's possible that my friend was actually quite late, or my friend's quite busy during that week, and therefore they had to cancel lunch plans. It's quite possible that my friend is going through a difficult time of their own, and maybe they needed to cancel lunch plans. So all of these things are equally possible to the idea that your friend dislikes you. Maybe we do find out through a series of probing that your friend doesn't like you at all. All right, so your negative automatic thought was maybe true. That particular friend does not like you. So what? So what does that mean for you? What does that mean for you in 20 years from now that you lost this particular friend over this? Okay, will you actually remember this instant? That is really what cognitive behavioral therapy is about. So you record an alternative response. Well, my friend canceled lunch plan. It doesn't necessarily mean that I'm unlikable. It doesn't necessarily mean that they hate me. It could mean A, B, C, and D. It could mean that they were very busy that week. It can mean that they're having a very hard time that week. It can mean that they just simply didn't plan right and they double booked themselves. All of these explanations are likely equally plausible to the initial explanation of they don't like me, they don't want to spend time with me. And based on this alternative response or alternative thought, how do you feel about it now? Okay, so your initial response was maybe an 8 out of 10 in terms of sadness. Does the sadness go down based on this interpretation that you have, the new interpretation that you have of this particular event? So the idea here is to follow the emotions. If you experience a very large dip in your mood, let's say you're on baseline, you're 6 or 7 in terms of your mood, or let's say baseline let's say your baseline sadness for you is 2 or 3 on any given day. That's just who you are. You feel a little bit of sadness, 1 out of 10, generally speaking. If there is an increase in that sadness by a few points, so something happens in the environment, a particular situation, like a friend canceling lunch on you, and then you experience a surge in sadness, or something happens and you experience a surge of stress or a surge of anxiety, it's probably telling you there is some kind of a negative automatic thought that is involved. So you follow the emotion. See what happens with your emotions. If there is a sudden change in the negative direction, chances are you're linking this emotion is linked to some kind of negative automatic thought. And then you can start working on that particular thought. First thing you need to do after you've followed the emotion and you linked a negative automatic thought. So as I was saying earlier, friend cancels lunch on me and I feel sadness 8 out of 10. I just followed the emotion. There is a negative automatic thought here that I'm thinking, which is that my friend does not like me. My friend does not want to spend time with me. Okay, so that right away is I linked the automatic thought with a emotion or with a behavior, which is maybe you withdraw from the situation. If you think that your friend doesn't like me or no one wants to spend time with you, You withdraw. Maybe that's the behavior. Then you look for distortions. So the automatic negative thought is, no one wants to spend time with me. My friend doesn't really like me. Is there a cognitive distortion here that's happening? Okay, so you go back to the list of cognitive distortions. What could it be? Well, for me, it's probably something like mental filtering, something we call mind reading. Okay, so maybe there's a cognitive distortion here at play. When I say that my friend canceled lunch plans because they don't like me and they don't want to spend time with me, chances are I'm mind reading. I'm attempting to figure out what emotions or what thoughts they must be thinking to help me understand or attribute their behavior. And obviously it's a distortion because you cannot read minds. It's impossible. And if you can read minds, then you have a whole different career on your hands here. But chances are you cannot read minds, and therefore this is a cognitive distortion. And you have to understand that this initial thought of my friend doesn't want to spend time with me, this initial negative automatic thought, this is just a thought. It may very well be untrue. It's a belief, right? So if you think your friend does not want to spend time with you, this is a belief that may or may not have evidence in support of it. So here's what you do. So once you're identified a certain negative thought that is associated with a particular situation, associated with a particular emotion, you have to challenge that thought. And that is what cognitive behavioral therapy helps patients do in the course of depression, anxiety, eating disorders, psychosis, whatever, you name it. First, you identify the negative automatic thought, and then you put it through a number of questions. What is the evidence for this thought being true? Okay? And what is the evidence against this thought being true? Remember, thoughts are thoughts. They are not reality. What is the evidence for the thought being true? What is the evidence against the thought being true? Okay, so that is the first question. And then the second question is there another alternative explanation for this? So remember, the negative automatic thought is trying to explain the situation to you. It's trying to explain people's behaviors. Could there be another explanation? Your friend cancels lunch on you. Could there be another explanation for this? Your friend cancels lunch on you. Your initial explanation is they don't like you. They don't want to spend time with you. Could there be an alternative thought here that also accounts for these facts? And then finally, when you've done the evidence for and you've done the evidence against, and you've thought about alternative explanations that are inconsistent with the initial automatic thought, so what? Who cares if your friend doesn't like you? Let's assume for a second that your friend doesn't like you, that your initial interpretation that particular friend does not want to spend time with you. What are the implications of this? Will you remember this a few years from now? What does this mean for you as a person, right? And I'll give you an example. And again, I really want you to get this because I really want you to use it. It's a very, very, very powerful skill. And what I'll do as well is that I'll post a worksheet, a cognitive therapy worksheet that kind of resembles this thought record, but gives you a lot more space to work in to try and challenge some of the automatic negative thoughts that some of you may be having over particular situations. So I'm going to upload that to your courses, but let me give you an example to make it even more concrete. Let's say there is this patient or this person who is very anxious about an upcoming exam, which is the situation here. So she records down the situation, which is her thinking about the upcoming exam, and she feels anxious. She records the anxiety as a 9 out of 10, which is really quite intense. And then Jenna starts identifying some of the negative thoughts she's having about this situation. And some of the automatic negative thoughts for her are things like, I will do horrible on this upcoming exam. I'm going to fail this upcoming exam. And then she identifies cognitive distortions. So these two cognitions, right? I will do horrible on the upcoming exam. I will fail this upcoming exam. What cognitive distortion are they approximating? And I think this is pretty easy. which is fortune telling. You're crystal balling. You're predicting how the exam is going to go, and you don't have much information to go on. So you're fortune telling, you're crystal balling, you're catastrophizing. You think the most horrible scenarios is going to take place when in fact you don't know. You really don't know. And also black and white or dichotomous thinking, right? I'm going to fail or I'm going to pass. There's no in between here. It's quite possible that she does mediocre on the exam, right? And in fact, that's the most likely scenario. So what she does is, after she identifies the cognitive distortion that may be at play here, she works on these particular thoughts. So what Jenna does at this conjuncture is that she takes these two negative automatic thoughts that are associated with this particular situation and these particular emotions. So I will do horrible on the exam, or I will fail. And then she subjects them to the questions that I introduced you to earlier, which first of which is, what is the evidence for these thoughts being true, and what is the evidence against these thoughts being true? Okay, so that is exactly what she does, is she identifies these negative automatic thoughts and subjects them to this first level of analysis. What is the evidence for the thoughts that she will do horrible on the exam or that she will fail? What's the evidence for this thought being true? And here's what Jenna does. She identifies two pieces of evidence, if you will, that are in support of her initial negative automatic thoughts. Remember, it's not the power of positive thinking, it's the power of realistic, helpful evaluations of situations. Okay, so she identifies two pieces of evidence in support of the thought being true that she will do horrible. One is that she's failed on an exam in the past, okay, which she takes as confirming that there might be trouble ahead. And then the second piece of evidence is that this time around, she doesn't know the material fairly well. And then here's all the evidence against the thought being true, okay? And then she identifies that out of a number of exams that she's done, and she's done a ton of exams at this stage, if she is a university student, she's only really failed one time, okay? So it's statistically speaking, given her baseline, it's unlikely that she'll do quite horrible or she'll fail on this exam. Another piece of evidence that goes against the initial negative automatic thought is the fact that her GPA is fairly okay, which suggests that she's a good student generally, and good students typically don't fail on exams and don't do horrible on exams. And then here's a third piece of evidence against the thought being true. She generally tends to be nervous before the exam, and then she tends to do okay anyway. So she's noticed this pattern in herself in the past. She used to get anxious, exactly as she's anxious right now with this upcoming exam, and she used to catastrophize, and then later on she does do the exam and she does quite fine on it. So she's identified that as another piece of evidence that goes against the thought being true. And then the very final piece of evidence that goes against the thought being true is that she's actually studied fairly hard on this exam. Okay, even though she may not feel like she knows the material fairly well, she studied fairly hard and fairly consistent with how much she studied in the past as well. So right away here, as soon as you do the analysis of evidence for and evidence against, you can see right away that there's just more evidence to support the thought being untrue, or more evidence against the initial negative automatic thought, which is that she'll do horrible, that she'll fail. More evidence against that thought being true, okay? Which, if we're reasonable people, if we're thinking individuals, if we're using critical thinking skills and scientific skepticism, it's just way better to use, to believe things that have more evidence in support of them. And in this particular scenario, the evidence is really not in support of the thought being true, okay? Yet, our entire body, our entire minds, our entire beings, if you will, reacts to these initial thoughts of, I will do horrible, I will fail. Your entire being reacts to these thoughts as if it's scripture, as if it's true, as if it will come to pass no matter what you do. But when you step back and you examine the evidence for and evidence against, you see that maybe not. Maybe there's logic is telling me something quite different. Here's so the alternative. I discussed two other important stages, which is an alternative explanation and what are the implications for this being true. And let's carry on with that example of Jenna, who was quite scared to fail a particular examination. So for the so what question, which is that third question that is part of her analysis, she comes up with these very interesting and very helpful thoughts. Even if I fail this exam, so what? Will she remember this in 5 years? Will it be remembered in 10 years? Think back on the things that happened to you 10 years ago, okay? And think back about all the mistakes, all the failures that you've had, as I don't know how old you were at that point, but think about all the things that even not even 10 years ago, even 5 years ago, even a few weeks ago. Think about the mistakes you've made as a human being. Do they feel as threatening and as upsetting as they did a few weeks ago, a few years ago? So really, time builds perspective, and this is really the purpose of this particular question. So what? So what? Will this matter in 5 years? Will it matter in 10? How will it impact your life in the big picture? Let's say the thought is actually true, is that you will do horrible. Okay, you do the evidence for and evidence against, and you find that the evidence for the thought being true, that you'll do horrible on the examination, it's just far outweigh the evidence against that thought being true. So what? How will this impact your life in the big picture? One exam in one course, in one degree of a four years of your life. How does this actually impact your life in the long term or in the big picture? And secondly, she identified the thought that, failing one exam is probably not indicative of your intelligence at all, which is in fact very true. And then finally, a very helpful question here that guides your brain about coping strategy. Can I cope if this thing that I'm predicting will go horribly? Can I cope if I fail this exam actually? And how will I be able to do that? So now the rumination turns into actually something that's positive and maybe turns into a plan of action. If this happens, I can do X, Y, and Z. Maybe you can create a behavioral plan. If I fail this exam, here's how I'm going to cope with it. I'm going to study harder for the following exam. I'm going to spend more time studying, so on and so forth. And then finally, you summarize the work you've done here and the work you've done here, which is about the so what question or the alternative explanation question. If the alternative response column makes sense for that particular negative thought, that is. In this particular negative thought about failing an exam, the alternative explanation thing didn't make sense. However, you can still summarize everything that you've done so far, all the work that you've put into challenging this particular thought, summarize it into a more realistic evaluation of the situation, which is the upcoming exam. And here's what Jenna did. She said, even though I am typically nervous before exams, I end up doing well. So historically speaking here, I'm going to be okay. The reality is, even if I fail, I think I can cope with the failure in the big picture. So imagine having this thought versus I'm going to fail, nothing's going to work out, I'm never going to be able to cope from this. So this really highlights that interpretations matter. And if you work on the interpretation, if you just spend a little bit more time working on this interpretation, making it more realistic, more in line with reality, it can actually make you feel better. At least this is what the research is telling us. How does CBT do for depression, for example? Here is a table comparing effectiveness rates so this is the number of people who do the trials, how many of them actually get better? So how many of them actually no longer meet diagnostic criteria for depression? These are MOAIs, are some of the very first antidepressant medications for depression, which are monoamine oxidase inhibitors, and they really worked on breaking down an enzyme that breaks down serotonin. Okay, so it blocks that enzyme from doing its job, meaning there's more serotonin that'll be left over in the brain. However, there are a lot of dietary restrictions when people are prescribed monoamine oxidase inhibitors, including getting off of things like cheese and dairy. So for that reason, out of 100 people who are subjected to monoamine oxidase inhibitors, so out of 100 patients who are taking this drug, 35 people drop out prematurely before finishing the complete course of the antidepressant. Out of the 65 that remain, 50% of them, so let's say about 32 of them, 33 of the people that remain in the trial, will see success in the sense that they will no longer meet diagnostic criteria for depression. And out of the 32 that saw success, if you follow them around for a year, okay, so they no longer meet diagnostic criteria, and then you examine them again a year later after the treatment is ended, you find that 50% of that 32, or around 16, relapse again. Okay, so they meet diagnostic criteria for depression a second time a year later after the antidepressant has been discontinued. So not great. Tricyclics, another class of antidepressants, relatively old, less dropout rates, a little bit higher in terms of its success rate, anywhere from 55 to 65%. Same story, if you stop the drug and then you examine people a year later, 50% of them would relapse into another episode of depression. SSRIs are the newer forms of antidepressant medication. Less dropout, more tolerated by people, so 25% is the dropout rate. Success, again, we're kind of about 60% here. Same story, relapse rates a year later, 50%. CBT, less dropout, because of course it's not a pharmacological intervention, meaning there's less untoward side effects of the treatment. So less people drop out of the treatment, about 15 to 20%. The success rate, very similar to antidepressants, about 60%. And then if you look at the relapse rate a year later after people have discontinued the course of CBT, only, and I say only, of course, 20 to 25% is still quite a large percentage of people relapsing, but comparing it to the relapse rates in antidepressant medication, I say only. So about 20 to 25% of people who discontinue CBT will relapse into another episode of depression. Similar rates for another treatment, cognitive behavioral treatment called behavioral activation, which is more focusing on, and I think I talked about this in the psychological disorders section. So this behavioral activation focuses more on engaging people again. So having them schedule pleasurable and mastery activities. Similar rates, 15% dropout, about 60% success rate, and about 20 to 25% relapse rates if you look at people again after 1 year. And this is just showing you, comparing the efficacy of selective serotonin reuptake inhibitors with cognitive behavioral therapy. So before the treatment, there was no differences in depressive symptoms. After the treatment, not a significant difference between SSRIs and cognitive therapy, but a year later is where cognitive therapy really counts, preventing about 50% of all relapses, as you can tell from this particular graph. There have been a number of criticisms of cognitive behavioral therapy, so it's not by no means a perfect psychological treatment. First of all, I showed you what the rates are like. Only about 55 to 60% or 65% of people will see significant reductions in their depression, anxiety, and whatever symptoms you're examining. So a substantial minority of people, it does not work for. Okay? So this is the second point here. The first point is that when it does work, when CBT does work, we're not entirely sure how or why that is. There have been some studies to suggest, for example, that changing people's interpretations is an important part of mechanistically how CBT works for something like depression or anxiety. But this is not a consistent mechanism. Other things may be at play here. Other mechanisms may be involved in something that's as complex of a treatment as cognitive behavioral therapy. Okay, so we're not really sure how the treatment works, is the first criticism. Second criticism is a substantial minority of people, anywhere from 45 to 35, 30% of people, it just doesn't work for. Okay, so it's a big minority of patients that the treatment simply does not work for. And then the third point here is that made actually by a feminist psychologist by the name of Janet Stoppard. She was one of the first to make an argument like that. She hails out of, or hailed, she's retired now, hailed out of University of New Brunswick. And she made the argument that CBT may actually reinforce oppressive conditions, because really what it teaches people to say, or teaches people to be okay with, are the crappy, shitty situations that people find themselves in. Okay, so if somebody is experiencing actual oppression in the workplace, at home, if they go to a cognitive behavioral therapist, the cognitive behavioral therapist will probably tell them it's not the situation that's making you feel this upset, it's your interpretations of the situation. So imagine the condescension here, right? Telling someone who is maybe racially or they're being discriminated against for whatever reason, sexual orientation, their gender, their employment, their class, whatever reason people discriminate and are prejudiced against people for. It's likely not the interpretations of these situations that are causing most of the distress. Most of the distress is probably being caused by these horrible oppressive conditions. And that's really the argument that Janet Stoppard made. And then finally, something interesting is happening. If you look at the effects of CBT for something like depression over time, you see that the how much the treatment works has actually gone down over the years. So it used to work a lot better in the 80s and 90s, and in fact, a much bigger part of the sample used to get better out of a course of cognitive behavioral therapy. However, this number has been going down decade after decade after decade. And the way researchers have explained this over time is that there could have been a bit of a placebo effect that comes out of CBT. When it was developed in the 60s and 70s, it was the shiny, brand new thing. People didn't think in this way back in the 1960s and 70s. Okay, so this was relatively, this particular treatment and the techniques that are housed within it were relatively novel types of technologies and interventions, and therefore there could have been an expectancy or a placebo effect attached with their novelty. However, over time, people have heard or have learned about CBT and what the nature of CBT is, and therefore it may have lost its novelty, and therefore it may have lost its placebo, a little bit of its placebo or expectancy effect. The next type of intervention that I will talk about, and it's in fact a big group of interventions that are still within cognitive behavioral therapy. So far I've been telling you about the classic or second wave cognitive behavioral therapy, which is mostly concerned about dismantling or challenging negative automatic thoughts. There is a new wave in cognitive behavioral therapy, and that's more of the acceptance and more of the mindfulness-based interventions. And mindfulness meditation has made its way as a bona fide and relatively efficacious, actually, technique in a number of different therapies. So it's featured in a number of different therapies, and there's lots of buzz around that concept of mindfulness. So what is mindfulness? Mindfulness comes from the Sanskrit word for lucid awareness, okay? And it really it pertains to our awareness or our understanding of the nature of experience itself, the nature of consciousness, okay? So directly translated, the word actually means remembrance. And what remembrance actually means is remembrance of the nature that is reality, the nature that is consciousness. So in the 1980s, mindfulness and contemplative techniques were brought over to Western medicine and Western science by someone by the name of John Kabat-Zinn, okay, who was very much interested in mindfulness and very much interested in meditation at the time. And he really thought that the technique of mindfulness and meditation could be brought over to the West to help a great deal of different conditions. And so the first application of mindfulness was in the 80s by John Kabat-Zinn, and he applied it to things like chronic pain. He really thought that it could help patients who experience chronic pain, and it turns out it really does. As is shown through a number of different studies of this type of treatment called mindfulness-based stress reduction, which was developed actually by John Kabat-Zinn. So John Kabat-Zinn defined mindfulness in this Western way, and he defined it as paying attention on purpose in the present moment, non-judgmentally. Okay? So basically paying attention to present moment experiences with purpose, so you're paying attention on purpose, and non-judgmentally. Okay? So you're accepting experiences as they come without being engaged with them, without being caught up or swept up in these experiences, no matter how negative or unpleasant these experiences are. And at their core, mindfulness meditation is really driven by, or is really associated with, Buddhist philosophy and Buddhist models of the mind. And there are really three important concepts that exist in Buddhism that guides mindfulness-based interventions. The first of which is that nothing in life is permanent. Okay? So not only is everything around you impermanent, everything around you fleeting, including life, but even the concept of self is that transient, impermanent thing. Self is a state that is continually changing, and therefore this third concept of not self. Okay? So the self as this unitary static thing does not exist. It's because everything is impermanent, including the concept of self. And if you cling on to things that are impermanent, and if you're unaware of the impermanence of life and unaware that there is no such thing as a static self, you do not exist in the same way you think about you existing. So the more you cling on to this concept of self, the more you cling on to things, the more you grasp, the more you struggle, the more you push away negative experiences, the more you try to hang on to positive experiences, and your ignorance around all of this clinging and all of this pushing away is the nature of life, and that is called unsatisfactoriness or suffering or dukkha. So mindfulness is really influenced by Zen Buddhism, as is explained in the previous slide, as well as it is a standard feature in a number of contemplative and meditation-based traditions. So mindfulness meditation at its core teaches people three essential skills that our understanding is telling us if you hone these three essential skills, it will lower distress, it will lower anxiety and depression symptoms, it'll make you have higher satisfaction in life, higher quality of life. And this is really in accordance with hundreds of different research trials that have looked at mindfulness and mindfulness meditation related skills. So what are these three essential skills? First is that you're learning to orient your attention at will, on purpose, to present moment experiences. You have better control or regulation of your attention. So that's the first skill. The second skill that is taught through mindfulness is decentering the self from the experience. Okay? Learning that this self is impermanent. And not only that, is that you learn that all of the experiences that you're going through, they're not really you. They're not synonymous with self. Okay, so you learn to distance or decenter yourself from your experiences. And then finally, another very important skill that relates to number two, the second skill there, is the acceptance of experiences. Okay, this is important for both positive and negative experiences. Okay, so when we experience a positive thing, we want to really hang on to it. If we experience a negative thing, we really want to push it away. And what mindfulness teaches is it helps you accept all kinds of experiences without judging them, and really without being too engaged with them, which is what the second concept talks about. How does it work? There have been several hypotheses, and the science is really telling us that it works mostly through three ways. One is what we call top-down influences on emotion. Okay? So the newer parts of the brain, the thinking parts of the brain, as mentioned in the stress and coping lectures, can actually exercise influence over older, more emotional parts of the brain. So if you train your prefrontal cortex, if you train your cognition enough, it can actually stop a pretty inflamed, if you will, or a pretty active emotional part of the brain. Okay, so that is top-down influence. There's a higher up structures within the brain that are associated with higher levels of thinking are able to quiet down your baseline very high emotionalities. Top down. Bottom up is mindfulness training actually can change people's pre-existing or baseline emotionality. It makes them less emotionally reactive over time. However, this second influence on emotion typically happens after many hours and years of meditative practice. You start seeing actual structural changes to the brain that happen that are associated with just dampening of emotional negative emotional responses to begin with. Okay, so you don't even need to hamper it from other parts of the brain. The actual structure that generates emotion, the actual levels of emotion at baseline, start to change, called bottom up. And then finally, how mindfulness meditation works, or how people experience symptom relief and people experience improvements in all kinds of psychological indices, is typically through cultivation of other really important resilience mechanisms. Okay, so these are the three ways of how mindfulness works. And the concept behind mindfulness, and this is how most people teach mindfulness in the beginning, is that you need to adopt what Buddhism calls a beginner's mind. You need to come to experiences as if you're experiencing them for the very first time. And the way I like to think of this is, I like to give the analogy of if you're old enough, or if you know about this movie called E.T. Extraterrestrial, directed by Steven Spielberg. The beginner's mind concept tells you that you need to approach all experiences as if you're E.T. And if you remember the movie, in the few opening scenes when E.T. finally touches down and he's at the kid's home, he's reacting to everything with this openness, with this curiosity, with this non-judgmentalness. Okay, and that is the stance that is often adopted in mindfulness meditation. You need to approach even things that you've, over the course of your life, associated with negativity, associated with judgments. You need to approach even these things with an open, accepting, and what is called a beginner's mind. Just a blank slate to your own experiences, if you will. At this conjuncture of the lecture, what I'd like to do is I'd like to invite you to do a short guided meditation just to give you a taste of what mindfulness meditation actually looks like. So if you want to follow along, and if you're a good sport, you want to do this, which I highly recommend you do, just to help you even understand the concept even better. What I'm going to invite you to do now is, if you're not distracted and you're able to do this, sit in your chair with a dignified posture. So spine as straight as you could, as comfortable as you could. And when you're ready, close your eyes. Just become aware of the sensations of sitting. Some of you may become aware of feelings of pressure in the back of your legs, in your back. Whatever it is that you notice, whatever it is that is the object of your focus, make note of it. When you're ready, I want you to shift your focus to the sensations of breathing. Just notice where you feel the breath most distinctly. For some of you, you'll start maybe noticing the rising and the falling of the abdomen. And if that is what you notice most intently, I invite you to continue observing the falling and the rising of your abdomen. For others, you may focus on the sensations of air at the end of your nose as you inhale and as you exhale. Simply become aware of the process of breathing without needing to change the breath in any way. We're just observing. See if you can notice the next breath from the moment it arises to the pause in between, to the moment it subsides. See if you can experience or become aware of the breath as closely as you can. As you will soon become painfully aware of, as you try to focus on the breath, your mind will wander. That is perfectly normal, perfectly natural. Minds will do what minds always want to do, which is to wander. If you notice your mind wandering, just take note of it and gently but firmly bring your awareness back to the sensations of breathing. It really doesn't matter how long you've been lost in thought. Just make note, observe the thought, and go back to the sensations of breathing. You may also start to notice a number of other experiences, perhaps in the room around you. Your sounds in the room, other sensations in your body perhaps, and the full gamut of human experience. Just make note of all of these things as well. Whatever experience that happens to be the object of your attention, make note and firmly but gently return to the sensations of breathing. There is really nothing outside of this practice of meditation. We are just simply becoming purposefully aware of the flow of our experiences without struggling with such experiences. Become the blank canvas. Become the theater upon which the full gamut of your experiences are projected. And you, as the ultimate purposeful, accepting, and open observer or audience. When you're ready, become aware of your surroundings again. Perhaps taking a couple of deep breaths. And as soon as you're able and ready, open your eyes. And perhaps take a couple of minutes to reflect on your experiences of this short guided meditation. Until next time.